Welcome back, Focus Learners. Today we are jumping straight into a really fascinating, though frankly devastating topic. We're looking at a disease that perfectly illustrates the complex interplay between a simple infectious trigger and our own immune system. I'm talking about acute rheumatic fever and its long-term consequence, rheumatic heart disease. This explainer is going to walk you through the entire clinical journey, from the initial microscopic trigger all the way to the macroscopic presentation and long-term management. Let's get started.
To keep things organized, here is our agenda for today's clinical review. 1. The global burden and trigger. 2. Molecular mimicry. 3. Clinical manifestations. 4. The revised Jones criteria. 5. Echocardiography. And finally, 6. Secondary prophylaxis.
Section 1. The global burden and trigger. Okay, look at this number. Greater than 40 million. That is absolutely staggering. Right now, worldwide, over 40 million people are affected by rheumatic heart disease, and it's causing over 300,000 deaths every single year. The biggest takeaway here, this is primarily a disease of poverty. Now, you might be thinking, I rarely see this in practice. Well, if you're in a high-income industrialized nation, that makes sense. Less crowded housing and better hygiene have practically wiped it out there. But in low- and middle-income countries, it continues completely unabated. It is literally the most common cause of acquired heart disease in children in those regions.
So how does it all start? The clinical timeline always kicks off with a group A streptococcal infection. Now, traditional textbook teaching almost exclusively focused on strep throat, right? But here's an important update. Recent epidemiological evidence points to a clear role for superficial skin infections in the pathogenesis of acute rheumatic fever, too. Following that initial throat or skin infection, there's this totally silent, asymptomatic latent period. It typically lasts anywhere from 1 to 5 weeks. And then, the sudden eruption of acute rheumatic fever symptoms.
Section 2. Molecular mimicry.
Okay, let's dive into this, because this concept is the absolute foundation of the disease. How does a simple skin or throat infection turn into a massive systemic attack on the body? The most widely accepted theory is something called molecular mimicry. It's basically a tragic case of mistaken identity. Antigen-presenting cells of our innate immune system present streptococcal antigens, mostly thought to be from the strep M protein, to our T cells. This fires up both our humoral and cellular immunity. But instead of just neutralizing the bacteria, this amped-up immune response mistakenly cross-reacts with structurally similar proteins in our own human tissue.
Let's break down the exact pathophysiology of how this plays out in the heart step by step. First, those confused cross-reactive antibodies bind directly to the endothelial cells on the heart valves. This binding flips a switch, activating an adhesion molecule called VCM1. Once VCM1 is activated, it acts like a beacon, recruiting lymphocytes. These lymphocytes, along with complement, literally lyse or destroy the endothelial cells. And when those cells burst, they spill human tissue peptides like laminin, keratin, and tropomyosin into the area. This triggers a secondary wave of cross-reactive T cells that invade the heart, amplifying the damage in a process known as epitope spreading.
Section 3. Clinical manifestations. Now that we've seen the microscopic damage, what does the patient actually look like? These are your primary clinical features. Polyarthritis and carditis are the heavy hitters here, showing up in the vast majority of patients. A really interesting clinical pearl about the joint involvement is that it's typically highly responsive to salicylates and other NSAIDs. Now, check out those bottom 2 bullets. During training, we hear a ton about erythema marginatum and subcutaneous nodules, right? But the reality is these classic skin manifestations are exceedingly rare in modern practice. We're talking less than 5% of cases. I want to pause for a second on Sydenham's chorea because its presentation is incredibly unique. Remember that 1 to 5 week latent period we just talked about? Well, chorea plays by its own rules. It has a uniquely delayed presentation, sometimes showing up after a prolonged latent period of up to 6 months. It primarily affects females and brings distinct neurological symptoms, most notably these characteristic darting movements of the tongue and the upper limbs. Patients also often experience intense emotional lability. And here is a critical takeaway. More than 50% of patients who present with chorea will also have carditis, so getting an echocardiogram is an absolute must. Section 4. The revised Jones criteria. Because there's no single magical blood test to confirm acute rheumatic fever, our diagnosis leans heavily on standardized clinical criteria. And these were recently updated with a major structural change.
Before you even apply the criteria, you now have to stratify your patient's population. You have to ask, am I dealing with a low-risk population or a moderate and high-risk population? The diagnostic thresholds actually split based on the baseline incidence of the disease in that specific area.
So, what does this all mean for your workup? The crucial point is understanding how these diagnostic thresholds shift. Let's say you're in a low-risk population. Joint involvement only counts as a major criterion if it's full-blown polyarthritis. But if you're in a moderate or high-risk population, the bar is lowered. Even monoarthritis or just polyarthralgia qualifies as a major criterion. We see the exact same logic applied to the minor criteria for fever. For low-risk groups, the threshold is greater than or equal to 38.5 degrees Celsius, but it drops to 38.0 degrees for higher-risk groups. The whole goal here is to make sure we do not underdiagnose this disease in areas where it's already highly prevalent.
Section 5. Echocardiography. When we're evaluating these patients, echocardiography is absolutely critical. It's how we separate an acute inflammatory illness from permanent, lifelong structural damage. And it's all about the timeline. In early acute rheumatic carditis, the valve leaflets, and it's usually the mitral valve we're talking about, are relatively thin and highly mobile. You'll see chordal elongation, annular dilatation, which leads to regurgitation. But fast forward years later to chronic rheumatic heart disease. After recurrent inflammatory episodes, those same leaflets become thickened, permanently scarred, calcified, and completely restricted, which ultimately leads to valvular stenosis.
And this image right here brilliantly illustrates exactly what that chronic damage looks like. What you're seeing is an echocardiogram of a 5-year-old boy with advanced chronic rheumatic heart disease. Look closely at the restricted anterior mitral valve leaflet tip during diastole. See how it's doming toward the interventricular septum? That specific rigid appearance is famously known as the hockey stick or elbow deformity. It is an absolute hallmark of advanced chronic leaflet scarring.
Section 6. Secondary prophylaxis.
Once we've managed the acute episode, our focus has to immediately shift to secondary prophylaxis. We have to prevent the recurrent attacks that drive that progression into chronic heart disease. The American Heart Association has standard guidelines for secondary penicillin prophylaxis, and they scale directly based on how severe the cardiac involvement was. It's essentially a rule of threes. If the patient had acute rheumatic fever without carditis, prophylaxis is for 5 years or until age 21, whichever is longer. If they had carditis but thankfully no residual damage, you bump it up to 10 years or age 21. But if they're left with persistent valvular disease, it's 10 years or up to age 40, and in some severe cases, it's a lifelong commitment.
Before we wrap up, I want to make sure we are crystal clear on a harsh, clinical reality. Yes, we use antibiotics to clear the initial strep infection. And yes, we use high-dose salicylates or NSAIDs to help with the terrible joint pain and the fever. But you have to understand, those anti-inflammatory treatments are purely symptomatic. There is currently no treatment for acute rheumatic fever that has been proven to alter the likelihood of developing rheumatic heart disease or reduce its severity. The cardiac damage is immune-mediated. Once that cascade is triggered, our acute medications simply do not reverse the trajectory.
Which brings us to our final thought for this explainer. We've just traced this entire disease, right? From the exact molecular mimicry all the way to the structural deformities of the heart. We know how it works. We have cheap, widely available penicillin to treat the primary infection and prevent recurrences. Yet this completely preventable disease still afflicts over 40 million people and kills hundreds of thousands a year, largely due to overcrowded living conditions and a lack of access to basic primary care. It is a truly tragic gap between our clinical knowledge and real-world global health equity. It's something every focused learner in medicine should take a moment to really ponder. Thanks for joining me on this clinical journey today, and I'll catch you in the next explainer.